Let's get started with Chapter 29 on family planning. The term family planning can include any educational, social, or healthcare interventions that allow people to plan reproduction. Optimal family planning involves shared decision making between patients and their healthcare providers. Nurses participating in family planning should be respectful of patients' choices and priorities and be careful not to interject their own biases. Family planning decisions are deeply personal and must be made by the people whose lives are most affected and who understand their lives and situations best, the patients themselves. It's important to keep in mind that the ultimate goal of contraception use is to prevent unwanted or mistimed pregnancies. One essential component of caring for clients as they are selecting a contraception that works for them is ensuring that the person is not currently pregnant. Most family planning choices center in one of three categories, either hormonal, non-hormonal, or permanent sterilization. The hormonal types of contraception can include combined oral contraceptives, progestin-only pills or POPs, LARCs, which are long-acting reversible contraception, progestin IUCs, patches, vaginal rings, contraceptives, injections, and implants. Non-hormonal contraception can include barrier methods such as a condom, diaphragm, sponge, cervical cap, natural family planning, withdrawal, copper IUC, and spermicide, which is a chemical or non-hormonal form. And permanent sterilization can include tubal ligation, tubal plugging, and vasectomy. Many methods of family planning can be quite effective, but we have to remember and have to educate our patients that the effectiveness is only as good as their adherence to continued and consistent use of the method once they've adopted or chosen a way to plan their family. One of the questions that you will hear providers asking now when leading these conversations is, do you want to have a baby this year? If not, what are you doing to avoid it? That seems to be one of the most effective ways to open up a conversation about contraception and family planning and to ensure that the method that they've chosen is still working for them and that they are adhering to it and using it consistently. So we're going to start with hormonal methods of contraception. We'll look at what they are and how they work. So let's start with combined oral contraceptives, or COCs. When taken correctly, the failure rate is very, very low. With typical use, it drops to about 92% effectiveness. Generally, how COCs work is there's 21 hormone-containing pills and then 7 placebo pills. When they take the 7 placebo pills, then a menstrual cycle is initiated. It works by increasing the viscosity of cervical mucus, suppressing ovulation, and thinning the uterine lining, making it inhospitable to pregnancy. So for the most part, healthy non-smokers can take the pill until menopause, which may help control the discomforts of perimenopause. However, we know that we have to screen people very carefully for any family history of stroke or any other contraindications. So an alternative method occasionally used with COCs is known as extended cycling. And it's an alternative method where they package 84 hormone pills followed by 7 placebo pills, allowing a woman to only have a menstrual cycle every 90 days or so. Alternatively, a client can take regularly packaged 21 hormone containing pills and just skip their placebo, start with the next pack. That's another alternative to using the extended cycling. There are some direct contraindications to utilizing COCs, especially those that contain estrogen. For patients that have a history of a migraine with an aura, personal history, or a female family history of blood clots, especially early in age, and a history of hypertension or a high risk of hypertension, they would be contraindicated because they would be at increased risk for having a PE or to having a DVT. Another hormone-containing birth control option is a POP, or a progestin-only pill. These only contain progestin, not the estrogen. So this is the artificial form of progestin. This is considered safe for breastfeeding mothers. This is one of the most popular ones selected shortly after birth. All 28 pills in a pack contain progestin. There's no placebo pills. And probably one of the most difficult parts of this is that for it to be fully effective, it must be taken within a 3-hour window each day. This is important when assessing whether this is a good option for a client or not. Are they the type that says, oh, I always forget to take my pills, or I'm very rigid about taking them every morning at a certain time? One of the primary side effects of a pop pill is to have a less regular period with more breakthrough bleeding. If pregnancy does occur when someone is on a progestin only pill, it's more likely to be an ectopic pregnancy due to the slowing of cilia in the fallopian tube in response to the progestin. There are two absolute contraindications to using a progestin only pill. Those would be breast cancer, current case of breast cancer, and acute viral hepatitis. A couple of things to keep in mind with progestin only pills. We do give it after pregnancy because it doesn't suppress breastfeeding, whereas an estrogen containing pill can affect breast milk production. Another thing to keep in mind is that all of these hormone containing methods, especially oral contraceptive use, can be affected by the use of anticonvulsants. So if you have someone who has a diagnosis of seizures, is on medication for that, there are several different medications that can decrease the efficacy of hormone containing oral contraceptives. The hormone containing birth control contraceptive patches contain both estrogen and progestin, is applied weekly for 3 weeks, and then followed by a patch free week, which causes a withdrawal bleed. The patch should be rotated in location at least with each application to avoid skin irritation, and should be applied on an area of the upper back, the upper arm, the upper buttock, or lower abdomen, but not on the breast. To avoid skin irritation, they should always place the patch on clean, dry skin that has not been treated recently with lotions, creams, or oils for at least a half hour after bathing. Sometimes people use a little bit of white powder so that the patch extra stickiness doesn't come up with a lot of lint over it. Another hormone containing birth control is the contraceptive injection called depomedroxyprogesterone acetate, which is DMPA, oftentimes referred to as a Depo shot or a Depo-Provera. It is a progestin only injection given every 13 weeks until someone decides to go off of it or doesn't show. Benefits can be less frequent, scant menses, but that can also be a drawback because they can have unpredictable breakthrough bleeding. Typically, it can take several months before their menses disappear completely. It is very good for clients who have heavy bleeding. Typically, it can reduce that. Interestingly, there's a couple of other side effects that are actually beneficial to some populations. One is a reduction in sickle cell crisis for women with the sickle cell disease, and it can reduce the frequency of seizures in women with epilepsy. For those populations, this might be a good option. DMPA works by inhibiting follicle maturation and ovulation. It also causes atrophy of the endometrium, changes to the cervical mucus that make it inhospitable to sperm. And with perfect use, the failure rate is 0.2%. With more typical use, the failure rate is closer to 6%, primarily because of people returning late for their injections. Optimally, when starting out on DMPA, women should get the injection within 7 days of their last menses. But it can be started at any point as long as there's a pregnancy test, even though there's no real proof that DMPA would be harmful to a pregnancy. Most clinics allow a 2-week grace period. Again, they want them back every 13 weeks. We know that ovulation does not occur for at least 14 weeks after administration. If they present for an injection more than 15 weeks later, they need a pregnancy test prior to administering the injection. And they also need instruction to utilize a backup method of contraception for the next 7 days after their injection. One concern that many patients have is about becoming pregnant after discontinuing their DMPA. About half of them can be pregnant within a year, and for a very small subset, it may take 18 months or longer to conceive. One of the most effective methods of contraception available today is the hormonal contraceptive implant known as non-estrogen etonogestrel, sold under the brand names of Implanon and Nexplanon. It's a 4 centimeter rod inserted under the skin of the inner upper arm. It works for about 3 years, and it works by creating changes to the cervical mucus and fallopian tube motility that impede fertilization. It also suppresses follicles from maturation and ovulation. There's some debate about whether a BMI greater than 30 makes this contraceptive less effective, but it appears that there was a 2016 study that supports the use of this method of contraception even with a BMI of greater than 30. The efficacy is decreased by the use of antiretroviral medications and is contraindicated in patients with a diagnosis of breast cancer. The most common side effect is unscheduled bleeding, and a majority of women ovulate within a month of removal. Another hormone-containing birth control option is an intrauterine contraception device, or an IUC or an IUD. These are T-shaped plastic devices wrapped in copper or containing progestin that are inserted into the uterus, as shown in the picture to the right. The probability of getting pregnant after 1 year of use is 0.1% with an IUC. The copper IUC works by inhibiting sperm motility, capacitation, survival, and phagocytosis. The copper IUC is also the most effective form of emergency contraception, but to be effective, it has to be inserted within 5 to 7 days of unprotected intercourse. While it can be used as EC, it's important to understand that it is not considered an abortifacient or disrupting an existing pregnancy. The progestin IUD causes inhospitable changes to the cervical mucus, endometrial atrophy, and variable effects on ovulation. Contraindications for IUC use should be including anyone with abnormalities of the uterine cavity, endometrial cancer, untreated ovarian cancer, persistent gestational trophoblastic disease, which if you'll remember is a molar pregnancy, current pelvic inflammatory disease or pelvic tuberculosis, or current post-abortion sepsis, abnormal vaginal bleeding suspicious for malignancy or pregnancy. Copper IUCs themselves are contraindicated for women with the rare Wilson disease or copper allergy. The most common side effect for IUCs is a change in bleeding pattern, of course. The copper IUC can often result in a longer, heavier, crampier menses, particularly as it gets started. The progesterone IUCs could cause spotting, unscheduled bleeding, and amenorrhea. The most awkward side effect is when partners occasionally complain of discomfort from the strings of the IUC poking the head of the penis. The strings are generally cut long enough that women can tuck them into the vaginal fornix, so the nurse can encourage patients to tuck this with their fingers prior to intercourse. There are some inherent risks with utilizing IUC. One of the most serious risks is perforation of the uterus at the time of the IUC insertion. Although rare, can happen in 1 in approximately 1,000 insertions. If the provider recognizes that the uterus has been perforated when they insert it, it's just removed, and then typically the uterine wall itself heals within about a month. It is typical for clients to have mild to moderate cramping or pain in the first week after insertion. However, sometimes clients can report some unusual findings that might indicate that it has perforated the uterus. Another inherent risk of the IUC is spontaneous expulsion of the device from the cervix. When that happens, it's usually within the first year and is accompanied by severe cramping. Emergency contraception is available as a medication or as a copper intrauterine conception, or IUC. There are 2 primary options in the U.S. for EC. Both are more effective in women who weigh over 165 pounds. So first is the levonorgestrel, the Plan B. This is available over the counter or by prescription, is most effective when taken within 3 days of unprotected intercourse, and it works by preventing ovulation. It can also be taken within 120 hours after intercourse. However, it is most effective in the first 72 hours. Because there's no effect on an established pregnancy, there's no need to have a negative pregnancy test prior to taking this medication. As with all EC, we do recommend that if someone does not have their menstrual cycle within 3 to 4 weeks after the medication, that they take a pregnancy test. The other medication available as emergency contraception is called ulipristal. It's also known as Ella. This one is available by prescription only because it does affect existing pregnancies. So clients need to have a negative pregnancy test prior to taking this. It may be used within 120 hours of unprotected intercourse. This is an anti-progesterone or a hormonal drug, so it does delay ovulation by as much as 5 days. And when clients take it, they should be counseled not to use any form of hormonal contraceptive use for 5 days after taking the medication. Let's move on to non-hormonal methods of contraception. One of the most common forms of contraception is the barrier method or the condom. Male condoms are generally less effective as contraceptives, but the best protection against STIs or other than abstinence. With typical use, the male condom has a contraception failure rate of 18% over 1 year. The female condom is more expensive and more cumbersome than a male condom, and it contains two semi-rigid rings attached to the opening of a nitrile tube. Placement of the female condom is similar to the placement of a tampon. Another barrier method is the diaphragm. This is a flexible saucer that is placed into the vagina to cover the cervix and does not protect against STIs. It has about a 12% failure rate within a year, and the fit should be checked anytime a woman gives birth, has a miscarriage or abortion, or gains or loses more than 10 pounds. Silicone diaphragms should be replaced every 2 years or sooner if someone's experiencing a lot of infections. Another barrier method of birth control is the contraceptive sponge. This is a 2-inch round spermicide-infused foam disc that fits over the cervix and is available over the counter. The sponge has a 12% failure rate over 1 year in women who have never given birth, and this is notable, a 24% failure rate in women who have given birth. Prior to insertion, the woman wets the sponge and inserts it with her fingers into the top of the vagina, and this sponge may be replaced for up to 24 hours prior to sexual intercourse and should be left in no longer than 30 hours. Another barrier method of birth control is the cervical cap and spermicide. The cervical cap is also called a fem cap. It is used with spermicide with each use and is notable for having a 32% fail rate with women who have given birth prior. This is inserted up to 6 hours ahead and can remain for 6 to 48 hours after intercourse. It should be reloaded with spermicide for each episode or session of intercourse. This lasts 1 to 2 years with proper cleansing of the device. Spermicide is a chemical that disables sperm. It can be used alone and has a 20% fail rate. It is used with condoms, diaphragms, sponges, and cervical caps. It can also be irritating to vaginal mucosa. The withdrawal method is not an effective form of birth control. It comes with a 22% chance of failure or a 1 in 4 chance of having a child. It can also be called coitus interruptus or pulling out, and it is an important point of education for those who are under the age of 30, as this seems to be a common misconception that this is an effective form of birth control. Natural family planning is known as the rhythm method of birth control. It relies on predictability of the female cycle and timing intercourse. This is typically used by families for religious reasons, in which they are opposed to utilizing a medication to suppress ovulation. Using the standard days method, a couple avoids intercourse on days 8 through 19 of the menstrual cycle, and with typical use, there's a 12% failure rate over 1 year with this method. Other natural family planning methods may include someone who evaluates symptoms of ovulation, which may include a slight temperature decrease just before ovulation, thinning of cervical mucus, and avoiding intercourse before and after ovulation. There are some procedures that are considered permanent sterilization. Of those, bilateral tubal ligation, typically done on postpartum day 1 or during a C-section or done laparoscopically, is called a postpartum tubal ligation or a bilateral tubal ligation. The hysteroscopic sterilization is the placement of a coil that creates scar tissue. It's called Essure, is what's used now. Adiana, that product has stopped production. It takes 3 months to create the scar tissue inside the fallopian tube. Vasectomy for men is another form of permanent sterilization. Only about 8% utilize a vasectomy, but it is considered the safest, most cost-effective, and it's an in-office procedure. Of note, these are permanent sterilization techniques. They are not meant to be reversed or to be used for long-term contraceptive needs and then later on surgically changed. However, there are some clinics that can offer a reversal of bilateral tubal ligation or a reversal of a vasectomy. Surgical reversals are not always an option, and nor are they always successful. A reversal of a bilateral tubal ligation, for instance, could result in a tubal pregnancy, and reversal procedures carry their own risks. Abortion. So, half of all pregnancies are unintended. In 2014, approximately 19% of pregnancies ended in abortion. There were just under 1 million abortions in 2014. Reasons women cite for abortion include inability to afford care for a child, not wanting to be a single parent, or problems with the partner. A woman may struggle with deciding on abortion and may change her mind several times. She may experience grief, loss, regret, or just as easily, relief. The majority of abortions are performed prior to 8 weeks, and almost 90% are completed prior to 12 weeks gestation. Medical abortions can be performed within 70 days of conception. A common regimen for medical abortion includes 200 milligrams of mifepristone followed by 800 micrograms of misoprostol 6 hours later. Surgical abortion is typically done by uterine aspiration and is also called dilation and curettage, or D&C. After 13 weeks, abortion is generally by dilation and evacuation, or a D&E. Nursing care includes observing patients for signs of hemorrhage, intra-abdominal bleeding, and monitoring vital signs, pain, and bleeding for at least 30 minutes after the procedure. Women who are Rh negative should be given RhoGAM immune globulin if they have a medical or surgical abortion. Nurses who participate in abortion care should know their own state laws. For example, some states require a waiting period between counseling and the procedure. In clients choosing to adopt out their child, it's important for nurses to recognize the struggle with placing an infant up for adoption and the fact that a client may change their mind several times. The client placing a child up for adoption will also experience grief and loss. The pregnancy and birth goals for a mother placing her child up for adoption are the same as those who will be raising her baby. Adoption services can be facilitated by a private or public agency or by a private attorney. An adoption may be open or closed, and the nurse should work with the mother to facilitate the amount and type of contact she would like with the infant after the birth. Fertility is the ability to get pregnant upon trying. Infertility is defined as a lack of pregnancy after 12 months of well-timed intercourse, 6 months if the woman is over 35 years old. Some couples may need information about ovulation and timing intercourse. Infertility can be related to male factors or female factors. Underweight or overweight women may be counseled to lose or gain weight and to induce ovulation. 6% of American couples experience infertility. Infertility testing starts with a history, blood and urine testing, as well as an exam for the female to assess the uterine cavity and patency of fallopian tubes, and semen analysis for men. It is important to keep in mind that 95% of couples achieve pregnancy within 24 months of trying. Fertility treatment oftentimes starts with medication Clomid, which is clomiphene citrate. It's a selective estrogen receptor modulator and common first-line medication to induce ovulation. Clomid typically increases the number of follicles available to ovulate. The risk of miscarriage or ectopic pregnancy is the same as with spontaneous pregnancies with use of Clomid. However, the risk of multiple gestation is increased by 7% when using Clomid. Artificial reproductive technology is utilizing laboratory to create reproduction. Intrauterine insemination is a procedure where sperm is washed and then introduced into the upper uterine cavity. In vitro fertilization is used to treat infertility due to tubal factors, severe male sperm factors, uterine or ovarian factors. With IVF, or in vitro fertilization, ovaries are stimulated, eggs retrieved by ultrasound-guided follicle aspiration, and then mixed with the cleansed sperm. Successful fertilization can be identified after about 17 hours. It can then be transplanted into the uterus or frozen for future implantations. Some of the choices they have are donor oocyte or donor sperm, and then the use of gestational carriers. There are many financial burdens with artificial reproductive technology and oftentimes high levels of stress among those who are experiencing infertility. And that's the end of chapter 29. Thank you.